So thank you very much. It's an honor to be here, both on behalf of myself and all the collaborators and colleagues and co-authors of this work, many of whom are in the audience, based both in London and San Francisco. So we're here to ask, why may HIV control in MSM have differed in London and San Francisco since 2006? First off, I'd just like to acknowledge that this is a multidisciplinary piece of work. There were many organizations that helped with data collection and with providing me access to various bits of unpublished work. And I would really like to express thanks for all of that, and indeed to all the men who participated in the behavioral surveys that we are about to see. So HIV in London and San Francisco is endemic across both settings. In 1981 and 1982 were the first cases in San Francisco and London, and currently there's very high prevalence in both settings, although this is notably higher in San Francisco, where we have 24% of MSM infected versus about 9% in London. But with the different size of cities and the different size of the MSM populations, that has led to similar total prevalent numbers diagnosed, about 13,000 and 14,000 respectively, as of 2010. Treatment has historically been the same, but there have been more recent treatment differences, with ART being initiated at any CD4 count in San Francisco and in London at less than 350. The San Francisco change has evolved over the years, with many clinicians moving towards earlier treatment, San Francisco General Hospital changing policy in 2010, and then the US government adopting a universal treatment policy in 2012, whereas London, we are still treating at less than 350 with certain provisos. So on that background, we saw since 2006 a decline in San Francisco, both in the number of undiagnosed, in the number of new diagnoses that we see, and also in the incidence estimates. Whereas London's have either fallen slightly or remained largely static. And so we're wondering, why is this the case? So we looked at extensive surveillance and behavioral data since 2004, and that was to evaluate how differences in risk, in testing, and in treatment coverage may have accounted for the changes that we see. So just to highlight some of the changes that we've seen, if we look here, this is a number of new diagnoses. So on the left in the bars, we've got total numbers, and on the right here, we've got a rate per 100,000 MSM in the line charts. So as we can see, London numbers static or certainly increasing the last couple of years, whereas San Francisco's have been decreasing. And certainly when we look at the last couple of years, particularly the rates, we see that this being quite a significant difference, although that the 2013 data from San Francisco is as of yet provisional. If we look at incidence estimates, this is from Andrew Phillips modeling from UCL in London. There are large confidence intervals, but a suggestion that the incidence is increasing, whereas the reverse is true for San Francisco. And then if we look at this slightly complex graph, we've got here on the left, the bar chart being the proportion of MSM who we estimate are unaware of their diagnosis. So as we can see in both settings, this is heading down, but in London, we've pretty much got a persistent 20 to 25% of men who are unaware of their status, whereas in San Francisco, we've fallen from 22% down to 7.5% in 2011. If we look on the right of this chart, this is the proportion of men that are estimated to be recently infected, and those through slightly different assays. We've got a very high proportion in London, about 20 to 25%, and a much lower percent in San Francisco who are estimated to be infected over the last 6 months. And particularly with this big jump in San Francisco from the undiagnosed, we did some sensitivity analysis looking at the 2008 figures and looking at incidence estimates, the number of new diagnoses, the number of in-migration estimates, so number of men coming into the city that were assumed or known to be positive, and the mortality data. And it does indeed look like this big drop from 18% to 7.5% is robust to those analyses, as it is indeed real. So why is that happening? That's the question, and some people have suggested that London is so much bigger than San Francisco. Why would this be a comparable analysis? I think it is for several reasons, not least the fact that there are comparable MSM hubs where insensitive interventions could be replicated. So if we look in London, we have Vauxhall in the boroughs of Lambeth and Southwark, where the hospital I work is, and here we see the highest prevalence of HIV among our MSM, and also the highest number of new diagnoses, and that's very equivalent to the Castro in San Francisco. So I think where there are lessons learned from each other, they can be replicable across both settings. If we look now at a little bit about what's been happening in testing over the years, we see that at the top, the average age in San Francisco and London has remained static over the last decade, since 2004. But what we see is a small increase in CD4 across both settings, and that's a very matched increase, so it looks like it's accelerating at the same rate. So very encouraging, though that is, it doesn't necessarily explain any of the differences that we see. So what about testing patterns? Let's look at self-reported testing. If we look at 2004, 2008, 2011, and we look at who's tested in the last year, what we see in that London, we've gone from about 40% up to 60%. And that, at least from self-report, is very similar to what San Francisco men report within the last 6 months. And their reporting within the last year is significantly higher, persistently up around the 70%. If we then look at the number of people that say that they've ever tested, in London we're improving. We've gone from 80% up to 90%. But again, in San Francisco, we've seen pretty consistent levels, nearly at 100% over the last decade. But if we go from self-report and look at what actually happens in practice and look at the actual number of tests within our sexual health clinics, what we see is that London has gone from 12% to 17% over the last couple of years. So we are increasing rapidly, but certainly we're nowhere near either the self-reported rate or the rates that we see in San Francisco, where they've persistently had about 30% testing in a sexual health clinic setting. And in London, about 80% of our men test in a sexual health clinic, so this 17% is probably quite a robust figure. It's maybe slightly up around 22%, whereas in San Francisco, a lot of men will test in family practice and other settings, and that number is likely to be much higher than the 30% seen there. So we've got a higher frequency of self-reported testing, a higher frequency of actual community-based sexual health tests, and some limited evidence that there may be more frequent retesting in San Francisco. So from the Magnet Clinic, 28% of people retest within 6 months, and from our London sexual health data, there are about 39% that test over a 1-year period. Difficult to compare those two figures, but there's a suggestion that there's higher retesting in San Francisco. So what are those men doing with the testing rates? Well, if we look at the risk behavior that leads on from that, this is a graph that looks at condomless sex and suggests that there's a slightly higher risk in London HIV negative men. Now, let's look at the top line first of all. So here we've got positive men in London reporting any condomless sex, and negative men in London, positive men in San Francisco, negative men in San Francisco. There's a high level of condomless sex in both settings. But as we've seen from the previous graph, where this is presumed concordant sex, particularly among the London negative men, because the testing rates don't seem to certainly be what's self-reported and are lower than San Francisco, there's much higher risk associated with this negative-negative serosorting. And if we look now at the serodiscordant or sero-unknown UAI, what we see is higher slightly in positive and negative men than San Francisco, but the time periods are slightly different. And we see certainly that negative men previously reporting about 20% serodiscordant, sero-unknown condomless sex versus about 10% in San Francisco. This does look like it's decreasing in London, but it certainly suggests that there traditionally has been more risk. Is there a way that we can actually look at this in real life? Well, yes, we can. We can look at sexually transmitted infection rates. And here we've got gonorrhea, so we've got London positive men, negative men, and San Francisco positive men, negative men, and then we do the same for syphilis, where we've got positive, negative London, positive, negative San Francisco for syphilis. And what we see is that the rates for STIs among London men are pretty similar for positive and negative. It does suggest there's a sort of homogeneous condomless mixing, whereas what we see in San Francisco is much different. We see very high rates among the positive men, but much lower rates among the negative men, suggests that there's less cross reaction of condomless sex between those groupings. If we go on to look at care cascade and see if the treatment has had any effect, well, London's got a very good care cascade once we diagnose people. We're very good at linking people and retaining people in care, and then viral suppression goes down largely because of our treatment initiation guidelines. Whereas across San Francisco, there's a more broad decline with linkage retention and viral suppression. That may be slightly related to the funding structures. The NHS is completely free at point of care, and there's free HIV care for anyone in the UK, regardless of immigration status, for the last 2 years. San Francisco has got a free program, Healthy San Francisco, that has a cap based on income, but there may be some logistical difficulties that prevent people entering into care. But if we add in the undiagnosed, or the presumptions of the undiagnosed, what we see is that London's main problem is this static population that we have of men that are remaining undiagnosed. Whereas San Francisco, it's more the fall at the end of the cascade, where people are being lost to follow up at different points along the way. So ideally what we would see is a sort of merge of those, and particularly in San Francisco with retention increasing, maybe with the Affordable Care Act, we may see even further reduction in transmission. If we look a little bit over time, we can see that in both settings, viral suppression among the diagnosed is increasing concordantly in both settings, which is very encouraging, but isn't as of yet accounting for the differences that are being seen. Now, this is where San Francisco changed. 2012 was when the US changed its policy, and it will be interesting to see how that changes over time with that, whether that increases at a different rate than London. If we look at substance use, Sigma recently did the ChemSec study, and there's certainly increasing suggestion that there's a lot of high risk at the moment in London. If we look at Hep C reinfection, we've got reinfection rates of up to 25% within 2 years in one London clinic, whereas in San Francisco the prevalence is stable, and it's largely from older infections. There's a Shigella and Flexneri outbreak in London, and we've also seen an LGV outbreak, and certainly some work from interviews done from the Flexneri outbreak suggests very high levels of risk, very high levels of drug use at parties, about 3/4 reporting recreational drug use, and up to a third reporting injection drug use. And if we look at crystal meth, one report from Sigma in the Vauxhall area, the MSM hub in London, suggests that about 15% of people had crystal meth use last year, and up to 3.5% reported some form of injection drug use. Whereas in San Francisco, crystal is stable between 10 to 12%, and it looks like that is, from some surveys, decreasing. So we've got a different risk pattern being seen, with a worrying increase in risk in London. This is just one example of a very innovative, I think, social marketing campaign from Stop AIDS in San Francisco, really reinforcing this suggestion that negative sera sorting only depends on when the last negative test was and how convinced someone is of that. And I think this is just really nice here, where you know someone's negative, but negative means maybe not using condoms, liking to hook up, particularly engaging in high-risk activity, or someone who gets tested. And I think we need to look to be doing much more of these social marketing in London, although Terence Higgins Trust has already started to do some innovative work. So just in summary, there's some caveats to this. One, the biggest one, is probably that we assume we know what our MSM denominator assumptions are, particularly for the negative populations, that we've got comparable reporting mechanisms across both cities, and that there's shared population characteristics among our MSM population. But assuming that those are all reliable, then I think the apparent reduction in proportion of undiagnosed HIV and in the new diagnoses in San Francisco is likely due to a higher proportion of negative MSM reporting more regular testing and possibly retesting, safer sex practices, particularly again among the negative population with increased condom use, disclosure and seroadaptive practices, and what I call a culture of positive openness. And I think this is where you've got a prevalence of 25%. It's very easy to be able to engage in the discussions along the lines of what we've heard, and to open up those discussions about use of condoms and about sera status. I think there's a critical importance for the prevention of HIV, of very high rates of testing, awareness and disclosure of status, and I think we really, particularly in London, need to aggressively challenge the safety myth of negative sera sorting. I think there's some key next questions that we have. How do we best implement novel risk reduction strategies in London? How do we achieve the San Francisco testing rates and status disclosure? I think this will be challenging given our difference in prevalence, but how do we achieve those good messages without our prevalence increasing to 25% in a larger, less dense, lower prevalence population? And what are the best campaign methods to do this? Is it social media, community marketing, or some other intervention? Who's driving the transmission? There's some good modeling work that maybe suggests which proportion of acute, undiagnosed and untreated infections, but I think there's still some work to be done on this, and particularly what's the contribution of in-migration, so of positive men coming into London from overseas, either to live, reside, or to come for a weekend. We know that approximately 20% of our diagnosis in 2011 picked up their infection overseas, but what we don't know is the proportion of men coming in transiently that may affect risk in London. And then I think this has been said several times at the conferences, but behavioural data really needs to be disaggregated by treatment uptake, by viremia, by PrEP use. And what I think would be really nice to see is that as we look to do behavioural surveys in the future, that we can try to get comparable markers that we can assess in different settings longitudinally over time. So I think that's it. I just want to thank again all the various collaborators, and these are some data sources we used.